Almost 20 years have passed between the approval of memantine in 2003 and the recent influx in the new Alzheimer's disease treatments that have been approved. So, based on your meta analysis, what was the biggest foundational barrier in the clinical trial methodology that created this void for promising drugs?
This is a really complex question because there are lots of factors that led to that giant gap. One of them just being that we kind of transitioned. Memantine, of course, is a symptomatic treatment, and the recent approvals are disease-modifying treatments or disease-targeting treatments. And so there has been a shift in the focus in trying to understand the disease and then address the fundamental characteristics of the disease to hopefully push towards something that could be a cure or at least total disease modification, something that lasts. Where things like memantine and glantamine and donepezil, they all address specific symptoms and can give people a boost, but that boost will just go away as soon as it's out of their system. And so that would be one of the big shifts as far as what led to us going from memantine to aducanumab and donanemab and lecanemab. But what caused that gap besides that are just a number of different issues. So one of the issues that caused that gap is that because we're shifting from symptomatic treatments to disease-modifying treatments, we need to start thinking about how we measure them differently. Those symptomatic treatments can give you that great big boost, and in some ways that may seem like they are better treatments because the boost is so large. But over time, being able to modify the disease will give you benefits that will outstrip anything you could get from these symptomatic treatment effects. What that means is that over the short duration of a trial, that treatment might not look as promising as one of those symptomatic treatments. So, like I said, this is a complex question, but one of the key things is that we have treated disease-modifying treatments like we treated symptomatic treatments, which look for large effects, maybe big effects on two outcomes that could be co-primaries. But because they're smaller treatment effects, and because you have to actually have disease progression in order to see disease-modifying effects, the effects that we see are smaller. And because we were stuck in a paradigm that was looking for symptomatic treatments, we ended up with looking for our effect sizes to be much bigger right from the beginning. And those were things that could have been measured by multiple primary outcomes, but that is a recipe for failure. In fact, it's a recipe that led to a 99.7% failure rate over that 20 years.